I am going to tell you about care of the child with Hirschsprung's. Okay, so Hirschsprung's disease is basically, I like to call it congenital aganglionic megacolon, because that's what the word megacolon sounds like in my head. So congenital, obviously they're born with it. Aganglionic, there's no ganglia inside the colon in the mucosa itself. Without ganglia inside the colon mucosa, there is no movement. So the pathology of Hirschsprung's is that it's delayed progression of stool through the large intestine. They are born with this. They can be born with just enough motility and ganglia in a certain portion for it to not be noticed until a little bit later in life, but usually it's diagnosed within the first couple of days because they start to look really puny and septic. So risk factors, it's 1 in 5,000 births is a child born with Hirschsprung's. Usually it's males, so 4 times more male than female in Hirschsprung disease. And we do see it very frequently in European and Eastern European cultures. Some of the cues that we'll be looking for is that this child is not going to pass meconium in the first 48 hours of life. They have super distended, swollen abdomens because they're not passing stool, but like a normal child, they are hungry. They vomit, frequently projectile vomiting. They appear malnourished and wasted everywhere but their stomach. And then we have some medical management that we'll go through, which is basically they have to go for a surgical removal of the aganglionic region. Okay, so for anyone who doesn't know what meconium looks like, if you've never tried to wipe tar off of your skin, that's what it's like. It is thick, tarry, sticky, dark, almost black, greenish black stool. And here's a beautiful picture of it. And I've also included some pictures of some little ones with these massive bellies that you can see is very common in the child with a Hirschsprung presentation. So you can see that they have very wasted legs. They're not going to be growing any fat. Normally babies are born and within the first couple of days they start, if they're not born with it, they start developing quite a bit of chunk on their thighs and their arms and around their little necks and in their groin, and these babies will just be wasting and wasting and wasting while their stomach gets bigger and bigger and bigger. So these babies are constipated, they're bloated and filled with gas. There is a thing called a fecaloma that's palpable. Basically, it is a poop tumor and it's palpable. Usually the any part of the colon, so it could be ascending, transverse, or descending colon could have the fecaloma in it. It depends on where the aganglionic cells are. The fecaloma would be prior to that, more proximal. They have putrescent diarrhea. Putrescent has got to be one of my favorite words. It just means so super disgusting. So it is the sickest smelling diarrhea ever. Basically what that is it's diarrhea that's coming out around this massive poop tumor because of the pressure that's building up inside the gut. These babies will have ulceration and bleeding from the rectum. They are anemic and they have hypoproteinemia because they are wasting. So you might see these children at a certain point start to develop almost an anasarca, where their face is going to get puffy because of the massive albumin loss that they've had, and they're so nutritionally deficient. They're also going to have a lot of electrolyte disorders because they're dehydrated, because they can't take in foods. So this is a surgical emergency that this child needs to be stabilized very quickly after birth or after it's discovered that they have Hirschsprung. And they need to be have their electrolytes replenished as best we can. Usually they will need PPN started until or if we need TPN. We will put in a request for a VAT team to come and place a PICC line in these little ones so that we can give TPN, but until then we'll give PPN through the veins of an IV. We might give them albumin just to try to prevent any other bleeding that could occur during the surgical procedure, because albumin helps to shore up the walls of the vasculature. Because these kids have electrolyte disorders and wasting, and they're so very fragile and septic, they're at a really high risk of respiratory decline leading to death, and heart issues as well. So we want to watch them and basically have them on an ICU setting of vital signs Q hour, if not more frequently. These are some of the things that we do preoperatively. We will, like I said, start IV hydration. The babies will be placed on NPO status. We will likely drop an NG tube and do gastric decompression to a low wall suction to try to clear out their gut a little bit. And then we will also do rectal irrigations anywhere from 3 to 4 times a day. And there's a picture here showing you basically how we would go about that. We use what we call a red robin catheter, which is a urinary catheter. We use it in the urinary tract, but in infants with Hirschsprung, we will use a red robin urinary catheter with what's called a coude tip, and that means that it has a little bend in it, and it also has some almost like a hard rubber ball in it so that we can enter slippery spaces without it doubling back on us. So we will use the Red Robin coude tip catheter in probably like an 8 French, maybe a 10 French, insert it into the rectum and just hook a saline flush on the end of it and flush them. And usually that's going to be in order. So the doctor might order 5 to 10 mLs of normal saline flush per rectum 3 times a day, as well as flushing the NG tube 3 to 4 times a day so that we can make sure there's no blockages in it while we're doing the low wall suction. We're going to give these kids antibiotics if there is enterocolitis involved. Frequently there is. And we're going to make sure to obtain consents for surgical procedures. Make sure that the surgeons and the neonatologists are involved. Also that we have social work and case management involved, because these kids are going to go home needing a lot of supplies and the parents are going to need a lot of support. This I find to be fascinating. It is a picture. If you read really closely, that it says that it is the Department of Pediatric Surgery, Dr. Virkas V, and he is holding a colon. that has been removed from a patient. I can't tell you the age of this patient. All I know is that this surgery was performed in a pediatric facility. So that is fascinating because that probably weighs 50 pounds. Here is a happy, fat little chunk who has an ostomy and all of the supplies that might be needed to deal with that ostomy while he has it. So, our post-operative nursing actions. What they're going to do is they're going to go in surgically, excise the aganglionic portion of the colon, and then make an ostomy. And the child's going to come out of surgery with that ostomy in place. We're going to make sure that it's pink and red and looks, kind of bloody. That's how we want an ostomy to appear. We're going to need to get a wound care or ostomy nurse on board so that they can help us to educate the parents on how to utilize an ostomy. And then, like I said, we need to have the social workers present because parents are going to need a lot of support emotionally as well as with resources. So when we deal with kids that have an ostomy, we obviously need to watch their skin. Skin needs to be a perioperative nursing action, not just post-operative, because the skin of a neonate pre-operative intestinal resection or colonic resection is going to be so fragile because they're so dehydrated, they're very septic, they're stretched to past the point, and we need to do, and they're probably having bits of diarrhea around the fecaloma continuously. So we really need to do very good skin care on these babies and use a lot of barrier creams. Make sure that everybody is performing adequate hand hygiene. So skin, we need to deal with comfort. These kids are going to come out of a surgical procedure with a large portion of their colon missing, and that's not comfortable. So we're going to provide as much comfort as we can with sweeties and sucking until they're able to take food by mouth, because there is going to need to be some period of bowel rest after the surgery. We want to maintain good fluid balance and electrolyte balance on these babies postoperatively. We want to deal with the colostomy, and then education. We need to make sure that parents understand that the removal of the portion of the colon and the placement of the colostomy it's not lifelong. It's not forever. It's providing rest to the gut until the gut can be formed back together using a surgical procedure called a reanastomosis. So they will take the lower portion that's left over of the colon and reattach it to the upper portion right above where the aganglionic cells were removed. And then that baby will no longer have a colostomy. It might take until they're 3-4 years old before that happens, before they do the reanastomosis. But we want parents to know that it's not a life sentence. They don't have to have it forever.